make a start. I'm Christine Smith and I'm one of the co-chairs for this afternoon's session. I'm the Deputy Chief Social Worker based at the Department of Health and Social Services. And this is my co-chair, David. David?
I'm David McDonald. I'm Director of the Department.
Okay.
Yeah,
sorry.
It's an organisation of disabled people who fight for our rights in this society. We've also just started up a Northern Ireland-wide organisation called Disabled People's Voices, which incorporates groups of disabled people across Northern Ireland. So we're developing.
Thank you. And David has told me that he's done a master's, so he has some understanding of research methodologies, which will be really helpful for us in this session. I think we all know the rules of engagement. We have 4 presenters this afternoon. Everybody has been allocated 10 minutes. It's a very strict allocation of time. Just to say to the presenters, we have green cards or red cards. We will show the red card 8 minutes in, so that you know you have 2 minutes to finish and wrap up. We are going to be strict with time to give every presenter a fair crack of the whip and their 10 minutes. We're not taking questions immediately after each presentation. Okay, so with no further ado, then I'm going to introduce our first presentation, which I'm in the glasses for, as you can't see. And it is Caroline Cunningham and Dr. Ashley McIlerney from NSPCC, and I'll let them introduce their topic.
Okay. Good afternoon, everyone. Thank you very much for the opportunity to share with you a little bit from our research over the past 12 to 18 months. My name is Ashley McIlerney and my colleague Caroline Cunningham. We both work with the NSPCC within the policy and research team. And this piece of work grew out of our involvement with an SPNI Project Outcomes Board, which would have started work about 18 months ago, to really look at could we capture some of the learning in recognition that LSCBs were further on this journey than we were here, and what could we take in terms of some of the lessons from their practice and their engagement in outcome measurement today. Our research aim, first of all, was to explore the ways in which LSCBs across England and Wales coordinate and ensure effective practice and improvement, and to capture that learning to improve safeguarding outcomes for vulnerable children here in Northern Ireland. I'm going to hand over to Caroline for the next slide.
Okay, just in terms of background, there's obviously been a lot of reports, inquiries, government reviews that have been carried out in this area. We just put a selection on the slide there. But since LSCBs in England and Wales came in 2006, they were subject to very early reviews by government and inquiries, and in Northern Ireland as well, since our own SPNI came in 2012, we had an early review too, just coming to a close. And there's been lots of developments which have kind of moved from these, also from inquiry reports on child deaths and scandals and child abuse, which have all influenced this area. There's a number of academics who write in this field. So we just put a few things here just in terms of, so the Monroe Review of Child Protection, obviously that's very key in terms of establishing that idea that LSCBs really are key, and key as becoming learning boards and driving learning improvement in the safeguarding system for children. Ofsted have obviously written quite a bit on this as the inspectors of LSCBs in England under the single inspection framework and a new joint targeted framework that's just come into being. So they've written in terms of what makes an effective LSCB, what are the different criteria that are needed. Very key, the 2013 revision to Working Together in terms of its guidance on LSCBs, that's taken up into our own statutory guidance, that section on SPNI, brought in something that was called a Learning and Improvement Framework in 2013 post-Monroe, and basically it was setting out the criteria that LSCBs need to do in order to become learning boards, in order to drive improvement in the system. That's something we'll talk a little bit more about, and key to that as well was service user involvement and practitioner involvement. Another big focus for LSCBs has been their use of data, and their use of data on a multi-agency basis. That Department for Education document started highlighting some of the criteria that multi-agency work should be starting to look at. There have been different reviews around effectiveness and stuff. C4EO, for example, they produced a study last year. There's been a more recent report which was commissioned by the Local Government Association. It was a major survey of LSCBs and practitioners looking at effectiveness. And this is really culminating, I suppose, in England. It's really come to the fore. David Cameron announced a review of LSCBs in December, which is going to be reporting in March, which has been led by the ex-president of the Association of Directors of Children's Services. So it really is a topical area at the moment.
Okay. It's also very timely here in Northern Ireland, where we're going to have a forthcoming review of SBNI. So in terms of taking forward this research to help collate and take some learning from practice elsewhere, we decided to use a learning cycle as a framework really to focus us on what our objectives specifically would look at for the research. So first of all, we were interested in how learning opportunities and issues are identified in LSCBs, how practice is reviewed and analysed, what consultation and engagement takes place, including what tools and mechanisms are used, how learning is cascaded to drive improvement, and how is the impact on children and families ensured and evaluated. So our focus from the outset was at a very practical level, so that some of the learning could be directly, would look at in terms of tools, mechanisms, and their applicability or transferability to our context here in Northern Ireland. So in terms of our methodology, first of all, we engaged 12 LSCBs, 11 in England, 1 in Wales, and the first 7 were really identified for us by the Association of Independent LSCB Chairs as those that had received, at that point, a good rating in the new single inspection framework. The other 4 we randomly selected in a very purposive way, because we wanted to ensure that we had representation across our sample of rural urban areas, and also some variation in population size. The method by which we collected our data was really about a semi-structured recorded telephone interview, and we used in vivo to analyse our transcribed data. We also have undertaken a review of learning and improvement frameworks, a desk-based review, to look at that document and what are the key elements, critical elements within that, and how it is used as a guide and as a framework by LSCBs. So in terms of the qualitative analysis, we approached this using a grounded theory approach, really to look at and tease out from the ground up what were the people who were living the experience as LSCB, business managers and chairs, what was their views and their perceptions of what it took to be effective in terms of safeguarding practice. So out of that, we have identified five key themes, essentially 5 key areas, that really help explain the journey that LSCBs have taken over the last number of years. And this will help us tease out really some of the key learning points. The first one is about a partnership process. And really, screaming out from the data of practically all of the interviews was that whole concept that it's a virtuous cycle, it's an ongoing process of learning and improvement, and that the framework document, the learning and improvement framework, is actually a living document to focus the partnership among the member agencies and to keep people engaged and committed to the process. Now, within this partnership process key theme, there are a number of sub-themes, and the first one is about building blocks. And I think it's really important to recognise that it's building on what people do anyway, not starting from scratch all over again, but looking at the really good existing practice that's there and building on that in terms of the data that we all already collect, in terms of the reviews that are already ongoing, and in terms of the research and the growing body of research that we have. The second sub-theme was the importance of relationships at every level between the LSCB and its member agencies, and also with clients and service users, all of the key stakeholders. Okay. Our third key theme, or our third sub-theme, is really the importance of strong leadership, and then also the importance of board mechanisms, the different things that a board or tools can use in terms of business planning annual report to focus people on the partnership process. Second key theme was about strategic knowledge management, and this is in recognition of all the different types of information and knowledge that we have available to us within our system, whether it's routine data, whether it's research reviews, whether it's service users' experience, feedback, etc. And it's about conceptualising that as a body of knowledge that's available to all of us to learn from and to drive practice on an ongoing basis. And the knowledge library concept was something that emerged as being potentially very useful. Now, that did acknowledge that there's particular challenges with data in terms of who owns data, people releasing data, and that recognising that that's a new and that's a big step for everyone in terms of trust and management.
1 minute.
Okay, sorry, I'm going to have to start gabbling here. Second was in terms for, do we need a specialist resource? Do we have that resource? Does it exist within LSCB structures? Was about how to use the data that's already there in terms of our routine data. The importance of deep dives, practice review and audit, and the valuable information that can give the system in terms of, particularly for practitioners and service users at that level. I'm going to hand over to you, Carly, for the last two.
Okay.
I'm going to have to ask you to just highlight your last things, because we don't have time now to talk to them, sorry.
Yeah, just very quickly, and then just further things around engaging and involving both practitioners as frontline staff and children and young people as service users. This was seen as most successfully done through the multi-agency and themed audit processes. Yes, let's go through. Yes, driving improvement was our fourth key theme. Literally, this was about the factors that were important in terms of being able to actually go from establishing that learning to actually being able to take that through to driving improvement. I'm not going to just read them there.
I think we're at time. You just want to flash up your fifth theme, and then we'll thank you very much for your presentation. I'm sorry you ran out of time. So can we all thank taskmaster, so be afraid, be very afraid. Thank you very much, ladies, and I'm sorry you didn't get to take over. It was very interesting.
The presentation's available anyway,
yes,
so and we have a report forthcoming in the next number of weeks, so it'll be available.
Okay, next I'm very pleased to welcome Dermot Blacken from West Belfast Partnership Board. Where's Dermot? I don't know where is Dermot. Where did you come from? You are hiding. So we'll wait till you get set up, Dermot, before we start the taking.
Can you put a hold on the clock, Chair? We'll just say transfer and make a video. I might be cheeky about that, but
I think you're stretching the rules here, Dermot.
Yeah, we do want parity across all presenters.
Okay.
Good afternoon, Dermot Blacken, West Belfast Partnership Board. Area partnership boards exist in all quarters of the city, north, south, east, west, and Shankill. Over the course of this brief presentation, I'm going to tell you about how we interpreted at local neighbourhood level a key public health message called Take 5, what we did, what we learned, but let's start with why West Belfast. West Belfast has, and is likely to continue to have the greatest concentration of the epicentres of deprivation in the north of Ireland. In our opinion, that's a systemic failure. Despite 10 years of the biggest spending on health and social care, the gap in health inequalities has got wider. People talk about moving to an outcome approach. What does that say about what has worked, what hasn't worked? As a society, we seem addicted to acute interventions at time of crisis. The prevention agenda seems to be lost and all that. Worst of all, the inequalities are capable of transmission from one generation to the next generation. We can't even interrupt that. In the city of Belfast, we're lucky that the chief executive of our council, health trust and public health agency sit together in a thing called the Belfast Strategic Partnership. They give direction to where health stuff should be going in the city. They come up with this idea, Take 5. One of their workers came out to see us and said, Dermot, we're going to do the buses. We're going to put this on the side of the buses and all the billboards and all this different thing. And I says, yes, you might see that flashing by on a bus. How are you localising that to what's happening in West Belfast? So we took this and turned it into this. So you see the circle thing, taking us the science, because it's a science conference. This Take 5 stuff, New Economics Foundation, they ground all the best evidence down and said if a human being can involve themselves in any of these 5 things, it'll be good for their emotional well-being and health. We translated it from, there's a Falls Park, any GAA fans, that's the Antrim, there's Falls Library, Keep Learning and Give. Behind this now is a whole series of activities where all of our community groups lined up together and put their activity for this month-long program. I'll pass that down. So this is the launch of it. Dr. Eddie Rooney, our local MP, Paul Maskey, and a range of other people. But rather than me talking, I want you to hear what one of the women said. This woman's name is Aisling. She attended for the first time in her life a mindfulness session that was part of our work here. So are you still on the clock, Charlie?
You're still talking, yeah.
Okay. Well,
Aisling, can you tell me your reflections on this evening's session?
It was very.
why is that not up there?
It's very educational in the point of view where I've actually got somebody who's practicing the mindfulness. For me, as somebody who suffers from depression and anxiety for practically a lot of my life, I feel that something like this would definitely help. Now, because there's so much involved in it, we're going on another session to do the practice, which I think will be fantastic because, it sounds absolutely brilliant. It sounds like something that would definitely help rather than the pills, rather than having to wait for appointments through the GP and that. Something that could be in the community, or would be in the community, would be absolutely fantastic. As somebody who finds it difficult to drive, find it difficult getting out, to have family and home commitments, to come to a public place like this, or and from Anderson's Town as well, have it there available, and also a lot of therapies if you want to do them privately or whatever, it can be very expensive, and something that's in the public forum and something that a lot of people are suffering in silence for, I think it can only do the world of good, and having it in public places where people come every day and don't feel as intimidated as maybe walking through a doctor's office or somewhere that's completely alien to them. I think it can only be a good thing, and it helped me come through the door, certainly tonight,
And if there was to be a fuller session in a big programme, would that be something you'd be interested in attending?
Absolutely, 100%. And I've got a very close relative of mine who suffers similarly to my situation, and she finds it difficult to get times away from work commitments and that, and something that would be in the community would be definitely up her street, and she would definitely have got.
Apologies for that. The PAC people were sure who was going to work. So we'll go back to. Yep. After our month-long one, we thought, what's next? What we decided to do was to drill down into one of the 5 areas, and that was keep learning. So we put on a week-long, again using the bubbles, a week-long celebration of all that's brilliant about West Belfast in terms of learning. It was brilliant to work with our Conway Mill and a range of other providers and help them view their interventions as public health interventions as opposed to just delivering learning. So there's the whole 2 minutes.
Yeah.
Oh great, I'm doing great then.
Yeah, great.
And you can hand out, there's the keep learning one. You can have a look down through that. And there we launched that, the Deputy Lord Mayor, this is in Conway Mill. Open University were absolutely superb partners in this. They really were brilliant. They brought their astrology people in and all sorts of different ones, grow your own ones and things like that. So what we learned, email is not enough. Despite great acoustics from social workers, and I am a social worker, I qualified in '96 in social work. Despite great acoustics, and we're connected in with directors of this, that and the other, I don't know if it made the blindest bit of difference. I offered myself up to go and speak to social work teams. It never happened, it wasn't taken up on. Prevention should be fun. Now, with a face like this here, I don't look like a fun sort of guy, but I do have a sense of humour. The onus is on making the activity as attractive as possible to get people in through the doors. Second one is agencies to collaborate together, they must see benefit. One of the benefits the agencies had was, I said to them, you're going to line up strategically with the Belfast Strategic Partnership, so you can tick that box in any future funding applications you're doing. And this was a second run on the lifelong learning.
1 minute.
1 minute. Nobody measures near misses. The day that somebody decides not to put a cigarette in their mouth, not to become a mum in their teens, nobody measures the near misses. Being skin could be an advantage. Each of these things were done for about £500, £600. Started off existing activity. Once people got into it, they started to do stuff. The big message is make it one door. That woman actually on that said about she could walk into the public library and talk about living with depression, talk about how she struggled with that, because nobody took the power away from her. She walked in of her own steam and decided what she was and wasn't going to talk about. And lastly, there's some of our lovely first ever dementia tour of Stormont as part of our lifelong learning. That was an amazing day to have 30, 40 adults with dementia.
Okay,
walking through.
Dermot, you've done really well.
Well, the last thing is, last thing is, if anybody's interested, anybody here has a contact, a footprint, I think in West Belfast, we're having an ideas workshop to do Be Active, which is our next phase of
Okay,
Take 5.
thank you very much. Can we all
You're
thank
very
Dermot? I hope you're all making notes of any questions or comments on these presentations as we go. Next, we're very pleased to introduce Dr. Martin Cannibal from Praxis Care. You're very welcome, Martin. We'll give you a minute to set up as well.
I think this thing's broke down somewhere.
You think so? What has happened?
Oh, no, there it is.
Oh.
Good afternoon. As you introduced, I'm Martin Cannibal. I'm a training manager with Praxis Care. This is a collaboration with Mr. Paul Webb, research manager in Praxis Care. And really this presentation reflects on some of the key themes to emerge from an evaluation of a basic awareness dual diagnosis programme delivered to Praxis Care staff. Consistent with the theme of the conference, the aim is to reduce the gap between research, learning and development practice and operational practice. The rationale for the study is premised upon the reality that dual diagnosis is for many people, or many people consider it to be the most significant clinical problem facing social care in the 21st century. Dual diagnosis, for our purposes, is defined as a coexisting mental illness and drug dependency. The research tells us prevalence rates range anywhere from 30 to 50% of people who present with severe mental health issues also have a coexisting drug dependency. Unfortunately, the research also tells us there's a significant capability gap in frontline workers in terms of their ability to engage effectively and work with people with dual diagnosis presentations. So the challenge for us all is to develop a cost-effective, empirically grounded learning and development strategy in order to build that capacity right across the social care workforce. The aim of the study then is to measure the effectiveness of enhancing what's known as participants' therapeutic commitment and their related practice readiness. And more broadly, we have operationalised what's known as therapeutic commitment as a core design and evaluation instrument in dual diagnosis, learning and development outputs. So therapeutic commitment. There's lots of definitions out there. The definition we used: an authentic, respectful, ethical stance built upon a robust knowledge and skills base and a self-belief and confidence in one's ability to make a positive difference in the lives of service users. So this conceptual framework can be broken down into three core strands, if you like. Role support relates to practitioners feeling that they're supported within the context of their own organisations. There's adequate policies and procedures in place. They have adequate line management support. It also relates to external supports in the wider social care community. They have sufficient links with other disciplines. There's a strategic focus across service provision. Role legitimacy relates to a feeling among practitioners that they have an ethical mandate and authority to intervene in the lives of people with dual diagnosis. And finally, role adequacy relates to practitioners' sense of having adequate knowledge and skills base in order to perform their job effectively. So you take those three domains together, and that's what goes into making somebody's sense of therapeutic commitment. And this in turn relates to somebody's sense of role security. Role security can be defined as somebody having the confidence and motivation to work effectively with people with dual diagnosis. So in terms of our study methodology, our data collection method was a questionnaire, the dual diagnosis problem perception questionnaire. As I say, this is built around those core concepts which underpin therapeutic commitment. So the subscales related to role support, role adequacy and role legitimacy. And the null hypothesis, if you like, is that the training programme has no effect on participants' therapeutic commitment. So the sample, there's 49 participants drawn from across practice care and mental health services. And the idea was that they would complete the questionnaire before the training at time 1 and then post-training at time 2. And then the analysis was carried out using paired t-tests. And this is basically the key findings across those three core domains. And statistically, the outcomes tell us that there was a large effect in terms of time 1 and time 2. Obviously this will be available to people to look at in more detail, and my colleague Paul is on hand afterwards to answer any questions you might have in relation to the data analysis. But in essence what we found was that the programme essentially met its objective. There's a significant enhancement of participants' therapeutic commitment, which tells us their practice readiness then was concretely enhanced as a consequence. But one of the things we did find as well is, if you think about role support, learning the outputs on their own are not enough. You need that underpinning policies and procedures, and you need a coherent strategy to be embedded across service provision. And unfortunately, well, my personal opinion is here in the North we lack a strategic umbrella, a strategic vision in regard to service provision with this complex service user group. Some limitations of the study. A control group would have allowed us to isolate more effectively the impact of the actual training, or what's known as the independent variable. A control group basically is a group of mental health staff who did not take part in the study but completed the various questionnaires. And from the perspective of Kirkpatrick Barr's outcome model, which is a model that tries to capture the application of learning to practice, this study doesn't capture that behavioural change and practice impact. It's really about capturing attitudinal change and knowledge gained. So that's only 2 of the levels within the Kirkpatrick Barr model. Some of the key messages. The study underpins our belief that therapeutic commitment can function as a core conceptual and evaluation template for the provision of future learning and development practice in regard to dual diagnosis. This conceptual framework forces you to be holistic. It forces you to think comprehensively in terms of content of the actual L&D outputs, and also in terms of the evaluation that comes at the end of that process. And to say training alone is kind of panacea. It's part of one piece of the jigsaw. But what we need is a whole range of learning and development outputs, a coherent sort of comprehensive workforce development strategy. to address the issue of dual diagnosis practice readiness. And obviously further research is required to test all of these assumptions. Thank you.
How you involve the people that this affects from the start in each of your projects, whether that's people within West Belfast or whether it's people who have been abused or those dealing with abuse, or those who are dealing with mental health and alcohol issues or drug issues, or mothers with pregnant children. Did you involve the people at the sharp end, the people who are receiving the outcome of the care and provision at any stage to find out how you should develop the research?
Okay, can we start with Caroline and Ashley, perhaps, in terms of the involvement of the end users you're really referring to?
I'm going to hold up our hands here, and we didn't. And that was really dictated by funding and capacity. And that's not an excuse, and that's the reason. And you know, sometimes we were doing this without any funding, and sometimes, you know, we listened this morning to how hard it is within practice and all of the demands on our time to make research happen and to actually learn from practice. So this